So tēnā koutou katoa, Kate Mila Falcha, bienvenue à tous, welcome. My name is Dr. Sinead Donnelly, a palliative medicine physician, host of this third Doctors Say No International webinar. We're an international network so far with 500 signatories from 19 countries to an open letter advocating that euthanasia, assisted suicide, is not part of medicine. We write that doctors should be left to focus on advocating for patients, to cure sometimes, to relieve often, and to comfort always. Please encourage your medical colleagues to consider signing this letter. We are privileged today to welcome Dr. Mark Komrad, who will present on medical euthanasia and assisted suicide for mental illness and ethical crisis. Dr. Komrad is a practicing psychiatrist and medical ethicist on the teaching faculty of Johns Hopkins University of Maryland. For over 20 years, he chaired the Ethics Committee for Shepherd Pratt, the largest non-profit psychiatric healthcare system in the United States. Dr. Komrad has written, lectured, and taught nationally and internationally about ethical issues in psychiatry. He served 6 years on the American Psychiatric Association Ethics Committee and the APA Assembly. And in these two capacities, he helped craft the APA position statement opposing euthanasia for the non-terminally ill, particularly psychiatric patients. Dr. Komrad has published widely on this topic and has lectured to colleagues in the United States, Canada, Britain, Europe, Scandinavia, and South America. Just to alert you that the chat function is disabled, so please write your questions on the Q&A tab. This presentation is being recorded and will be available in the next month. Dr. Catherine Farrier from Canada and Dr. Frank Brennan, Australia, are on hand to attend to your questions at the end of Dr. Komrad's presentation. So I will now hand over to Dr. Mark Komrad.
Thank you so much, Sinead. I appreciate it very much, and very glad to be speaking today on behalf of Doctors Say No, which is an organization, I'm one of the founding members of that, of physicians from around the world who have subscribed to a manifesto that opposes the idea that physician-assisted suicide and euthanasia are medical treatments and very much promotes palliative care as a way of helping suffering. And I invite you all to consider looking us up on the web at doctorssayno.net. So my task today is a difficult one and a painful one. It was Melville who wrote, "Woe to him who seeks to please rather than to appall." And for me, this is very much a tale of woe, full of sound and fury. It is not a pleasant topic. It is extremely contentious and frankly has really become, for me as a practicing clinician treating patients and as a medical ethicist, really a passion and something that I have been very involved in. Really, Camus reminded us there's but one truly philosophical problem, and that is suicide. And as somebody who traffics in philosophy and ethics and in psychiatry, the intersection of those two very much lie in suicide. And I really want to be clear, as I will make the case to you today, that is exactly what we're talking about today. We're talking about a form of suicide that has become legalized and turned into a medical procedure. And as a psychiatrist, as well as an ethicist, I'm very concerned about that as not good clinical practice, not good medical ethics, and not good public policy. So there have been many different terms that apply to what we're talking about today: physician-assisted suicide, voluntary euthanasia, compassionate assistance to die, physician-assisted dying, medical aid in dying, that's a preferred term in Canada, MAID, death with dignity. There's even this curious organization called the World Federation of Right to Die Societies that is trying to promote a new term here, dignicide. And you can understand how loaded all of these things are. As far as I'm concerned, this is so much verbicide. George Orwell wrote in 1984 his book, "If thought can corrupt language, then language can corrupt thought." So let's get our language and terminology clear. And I want to define some terms that we're going to be using today. In increasing moral complexity, I'm going to talk about three levels. The first level is palliative care. Palliative care is provided to people who are suffering, whether they're at the end of their life or not. And in this particular approach, which is very well established now for over 50 years and is a specialty in its own right, a doctor may, under certain circumstances, withdraw life support, provide comfort care, get out of the way of death. But the next level that is in this family of interventions is called physician-assisted suicide. And this term refers to a doctor writing a prescription for oral medication for a patient to administer at the time and place of their own choosing. The medication may sit around for a while. As a matter of fact, in some jurisdictions, it's been shown to sit around for as long as over 4 years, maybe in the closet, hopefully before well protected so that one's perhaps suicidal grandchild doesn't discover them and self-administer them to themselves. So this is physician-assisted suicide. And perhaps the most controversial and morally complex level is euthanasia. And in euthanasia, a physician is present at the time that the patient dies and actually produces death, actually kills the patient through an intravenous lethal injection. So let's just be clear, particularly about the terms physician-assisted suicide and euthanasia. Now, we've been using this word suicide, and I just want to reference here in America, we have the Centers for Disease Control, which has defined suicide in a very clinically familiar way that's been familiar to physicians and psychiatrists for centuries as death caused by self-directed behavior with an intent to die. And as you can see by this definition, any self-directed behavior that is choosing to die would fall under this eponym suicide. However, the American Association of Suicidology back in 2014 decided to declare legal physician-assisted deaths should not be considered to be cases of suicide. They went on to say these people do not want to die, but to end their suffering. And frankly, as a psychiatrist, I will tell you that patients that I deal with psychiatric disorders who are suicidal very much do not want to die. They simply want to end their suffering. So that category of patients in one category or another, they really have very much the same motivation. Camus again said to misname things adds to the world's misery. Frankly, to remove the term suicide from the procedures that we're talking about is, back to Orwell again, a kind of newspeak, as he talked about in that book. The editor-in-chief of the Journal of Ethics and Mental Health said using the term medical assistance in dying, which is the Canadian term, is an attempt to separate suicide from its value-laden meaning and thousands of years of moral reflection. As a matter of fact, what it does is it sets up two different tiers: good suicide and bad suicide. The suicide we should prevent, as we have been doing both as individual clinicians and with public health initiatives with suicide prevention. And then there's the suicide that allegedly we should provide, that there are some patients we should prevent and other patients that we should provide. And the kind of suicide that we should prevent is associated with conditions that we call a pathology, whereas the suicide we should provide is being called a medical treatment. And this is very confusing. I think it's confusing for clinicians. It's confusing for society. It's especially confusing for patients that are demoralized and wanting to end their suffering, as we mentioned before. Because of this confusion, as a matter of fact, it finally occurred to the American Association of Suicidology that it is confusing and that, in fact, these cannot be separated. And so, in March of this year, they withdrew their statement that physician-assisted suicide should not be considered suicide. And they said that that statement has been retired and a task force will determine any future positions or statements on this subject. So they got a great deal of blowback from clinicians, especially, and from members of society about setting up a confusing two tiers And so they have backed away from that. All right, let's look at some of the actual experiences that have been going on, as a matter of fact, for over 2 decades in some jurisdictions around the world in which not only is physician suicide and euthanasia legal, but psychiatric patients have been included in that. And let's see what we can learn from that, because our focus today is on psychiatric disorders. Both the Netherlands and Belgium, as well as Luxembourg, in 2003 opened the gates to what at that time seemed to be the low-hanging fruit, people with terminal illness. But they went on to say that that's not going to be the defining criteria. The defining criteria is going to be people who have insufferable conditions that they cannot suffer, and for which there is no significant prospect of improvement with treatment, not necessarily terminally ill, and that opened the door to psychiatric patients. So this is what's been going on first in the Netherlands. Since 2003, there have been overall a 480% increase in the number of euthanasias in that country. Now, let me make a point that in any jurisdictions where they legalize both assisted suicide and euthanasia, 99.9% of the cases end up being euthanasia. Why? Because patients would much rather outsource this as a medical procedure to a doctor to start an IV to terminate their lives, rather than to take what is essentially a box of barbiturates, infamously known as the box of barbs, that they have to feed themselves if they're capable. So if you make both of them legal, euthanasia is far and away the preferred method that patients will choose. In 2022, in Netherlands, almost 9,000 people had euthanasia. 5 out of every 100 human beings in the Netherlands died at the sharp end of a doctor's needle, deliberately trying to kill them. 5 out of 100, 5% of the entire population. And in this New England Journal article, as many as 23% of these procedures may actually go unreported. So this is an underreporting. Now, let's look at psychiatric disorders in that country primarily. And when I say psychiatric disorders, this excludes dementia. There's a whole other lecture that I can give about dementia and euthanasia and advanced directives and some of the misadventures that have occurred in euthanizing people with dementia. But we're now looking at other psychiatric conditions. Now, when we're talking 9,000 cases, you might say, well, these are very small amounts, but they're extremely significant. You can see how it's grown over the years. There was a little bit of a setback in 2020 due to some blowback that's occurring in society there, but then it took off again in 2021, 22, 115 in those years. In 2022, if you kind of just do the math, it's an average of 3 psychiatric patients euthanized on request every 10 days. Now, in the Netherlands, there are 2 different pathways for receiving euthanasia. One is via your personal physician. And as a matter of fact, when it comes to non-psychiatric disorders, 85% of patients who are euthanized in the Netherlands are euthanized by their own treating physician. Their exhausted treating physician who has been trying to manage their case and ultimately is personally responsible by their act on request for their death. However, a lot of physicians are uncomfortable doing that, particularly when it comes to psychiatric patients. So the Netherlands has set up an additional pathway, the Levenseinde Clinic, which has been now renamed into the Euthanasia Expertise Center. And it is that center that's actually responsible for the majority of psychiatric euthanasias. So in fact, if you look here, these are the percentage of psychiatric euthanasias that have been performed in this specialty clinic. You see in 2021, it was almost 90% were performed there. Why? Because treating physicians General doctors and treating psychiatrists are extremely uncomfortable about providing suicide for psychiatric patients. So they set up these 60 traveling teams. These physicians who are evaluating the patients and seeing if they meet criteria to have a condition that is unbearable. They decide this person's has an unbearable condition, this other person doesn't. They also decide whether or not that there is any prospect of improvement. The typical evaluation is between 1 and 2 hours in this, and the euthanasia is provided in the setting of these traveling clinics. Again, this is for psychiatric patients, and it covers 2015 to 2021. Now, here's some data about patients who were euthanized by their, it's not clear whether it's their own doctor, but let's just say not the Lebensende clinic. 66 psychiatric patients. You can see some of the diagnoses here. Obviously, mood disorder is one of the most common, anxiety, PTSD, psychosis. But what's really especially important is that 52%, half of all of these patients, actually had personality disorders. Now, some of them had comorbid personality disorders with some of these others. So that's why it adds up to more than 100%. And really astonishingly, Scott Kim of NIMH, one of the great scholars of the Netherlands situation with psychiatric patients, has shown that almost 1 out of 3 of them have not had any history of psychotherapy, which is the definitive state-of-the-art treatment for personality disorders. They've been euthanized despite the fact that they didn't partake of this core and critical evidence-based treatment approach of psychotherapy. What's also interesting is that over half of these patients refused 1 or more recommended treatment. The state of the art of medical ethics is that patients are allowed to refuse treatments in psychiatry, except when they're in imminent danger to self or others, and then they can be involuntarily hospitalized. And then there's a whole set of legal steps that one has to go through in order to be able to give them involuntary medication and so forth. But that's a very minority of people in psychiatry. So these psychiatric patients, 66 psychiatric patients, over half of them refused a recommended treatment, and yet they were approved and given euthanasia anyway. And 41% of these we know were euthanized by a psychiatrist. The psychiatrist actually was at the blunt end of the needle for 41 of these patients. What we don't know is how many of them were the actual treating psychiatrist versus, a euthanizing psychiatrist. But the fact of the matter is, since most of them happen in the Lebensende clinic, probably the euthanizer was a psychiatrist, but not the treating psychiatrist. Interestingly, the majority of these people were female, not male. That's a whole other discussion about why these procedures seem to be leaning towards females rather than males. So this is a common thing. Now we've raised a whole generation of people and whole generations of psychiatrists in which euthanasia is a treatment option, if you will, for psychiatric patients. So then the question is, when a patient comes to you, as has happened to 50% of Dutch psychiatrists last year, received requests for euthanasia from their patients, those psychiatrists are put into a position as to whether this is a patient for whom their suicidal issues should be dealt with and prevented, or should this patient be provided their suicide. In fact, this study here showed of the 66 cases that I showed you, only 8% had adequate assessment of their capacity, which is a very important part of evaluation for euthanasia. You want people to have full capacity, full competency to make this decision. And physicians frequently stated that psychosis or depression may or may not have impacted capacity, but provided little or no evidence regarding how they came to the conclusion that even though they were psychotic, even though they were depressed, that they had capacity. And there's no explanation for that, by the way, nor are there standards in capacity assessment, which is a subcategory of psychiatry, forensic psychiatry, for how one actually determines capacity adequately when it comes to not whether a person should have surgery or not, or medication or not, but the irreversible decision of ending your life. So I also want to mention that now in these euthanasia regimes, organ donation is being linked to euthanasia. Belgium and Netherlands have been doing it for a while. Interestingly, in 2018, a Dutch law passed to make it the default that you are an organ donor unless you opt out. So the entire country is an organ donor unless you've opted out. And if you have euthanasia, your organs are harvested unless you opt out. Now, this is a study of organ donations for patients, psychiatric patients who've had euthanasia. If you look at all euthanasias in the Netherlands, only 1% of the euthanasias were psychiatric patients with psychiatric disorders, as opposed to 99% with somatic disorders. However, if you look at all organ donations after euthanasia, psychiatric patients are vastly overrepresented. 71% of all post-euthanasia organ donations in the Netherlands are psychiatric patients, so they are 70 times overrepresented in this particular aspect. And they looked at 24 donations, and you can see the diagnoses here. Note that 5 of them had personality disorders. So I bring this out because who is really the most optimal candidate for organ donations, right? It's typically psychiatric patients. They are not riddled with various cancers and other kinds of severe somatic diseases, or dying of infections. They generally have pretty clean organs. So what we see is that psychiatric patients who determine that their life is meaningless, that they're in despair, that there's no reason to live any longer, are attracted, indeed, I would even use the word to say implicitly coerced by this virtue opportunity to say, okay, my life may not mean anything to me anymore, but at least if I get euthanasia, I'll have an opportunity to give my life meaning by providing organs for somebody who needs them. And so that is a very seductive virtue opportunity. I have here that there was actually a notion in ancient Rome, actually it's called Roman suicide, quote from Horace here, it's marvelous to die for one's country. Many people in ancient Rome who saw that they were a burden on their family, who saw that they were using their family resources and causing their families distress, would choose suicide, and that was considered a noble act, a virtuous act. Here is one organ donor who was euthanized, who had psychiatric disorder. I thought the knowledge of having full autonomy by way of maid was comforting, but when the possibility of organ donation was added to it, the sense of elation is the only appropriate word for me. All right, let's turn to Belgium, Netherlands' neighbor. And here's the story in Belgium. Since 2003, there's been 1,000% increase. They've been much more robust increase there. Almost 5 out of every 100 human beings in Belgium dies at the sharp end of a doctor's needle. If you look at only the euthanasias, if you look at only the population under age 60, euthanasia is now one of the leading causes of death for people under the age 60 there. 1 out of 3 people who die in Belgium under the age 60 now are dying by euthanasia. And again, this New England Journal article looked at significant numbers of unreported cases. Now, turning specifically to psychiatric disorders, you can see how this has climbed. But interestingly, Belgium made, frankly, a very wise change in an otherwise unsatisfactory situation. In 2019, they made guidelines. It's actually not accurate when I said a change in law. It really should be a change in the guidelines, urging that when dealing with a psychiatric patient for euthanasia, that the psychiatric patient must try all evidence-based treatments. Remember back in the Netherlands, we showed that 56% refused one or more evidence-based treatment. Well, there was tremendous pushback in Belgium, especially, and they instituted this new approach of trying evidence-based treatment and also urging people, euthanizing physicians to involve the family and consult with the family rather than to exclude the family, which had been done at the request of patients who didn't want their families involved. Anyhow, you see how it knocked it back in 2019. It's come up again a little bit, but it's kind of done, it's suppressed these numbers somewhat. Now, what are the attitudes of this whole generation, 20 years of euthanasia, including psychiatric patients in Belgium? Well, it's become normative. 75% of psychiatrists said euthanasia ought to be available for people who have sole psychiatric illness. And 8%, small number, but still a remarkable number as far as I'm concerned, are willing to perform the euthanasia on their own eligible psychiatric patients that they had been treating, whose suicide they've been trying to prevent in the course of that treatment. Say 8% say that they're willing to reach the point where rather than preventing it, that they would be willing to provide it. Now, looking at some of the diagnoses here is 57 psych patients euthanized in 2019. You can see some of these disorders. There's a whole discussion to be had about autism and developmental disorders, which are now coming to light in both Belgium and the Netherlands as an increasingly common diagnosis for people. And you can imagine the controversies around that with proxy consent by their guardians. But again, we see personality disorders, 45% of the total. What are those personality disorders? Well, the most common personality disorder diagnosis, which will not surprise anybody in the mental health professions, is borderline personality disorder. And I'm not going to unpack clinically why that's no surprise, but just to note, many people are familiar with borderline disorders. These are people who are, have a lot of chronic suicidality, frequent suicide attempts. There were undefined, and the next most common category and the third most common was a dependent personality disorder. All right, let's come back across the Atlantic to look at Canada, where it's called MAID, or Medical Assistance in Dying, which was legalized in 2016. And many authors have used the term euthanasia frenzy to describe what's happening in psychiatry in Canada, which has become the most robust and, if you will, frenetic suicide regime in the world. So here's what's happened in Canada since it's been legalized. Remember, Netherlands had a 480% increase over the course of 2 decades, and Belgium 1,000% increase. Well, here in just 6 years, there's been a 3,000% increase in euthanasias. Again, the majority of people euthanasia, very few people choosing assisted suicide. 4% of all Canadian deaths are now euthanasia in 2022. Quebec, which is especially besotted with this practice, that 7% of Quebec deaths, 7 out of every 100 human beings in Quebec dies by euthanasia. Now, in 2021, there was a law that suddenly expanded euthanasia. At first, it was confined to terminally ill people, although a unique Canadian term, which was people with death in the reasonably foreseeable future. Nobody knew what that meant. It was not statutorily defined. And many people who were not terminally ill were allowed to have euthanasia. But that kind of distinction, are they terminal or is death reasonably foreseeable, was really effaced with this new bill that set up 2 tracks. One track is people who, we'll start with track 2, people whose death is reasonably foreseeable, who are terminally ill. And they previously had to wait 90 days between applying for euthanasia and receiving it. With this new law, now they can have euthanasia the same day they ask for it. Track 1, however, follows the Benelux model, Belgium and Netherlands, and that is chronic illness and disability that is considered irremediable and intolerable are now eligible as of last year in March, and they have to wait 90 days. And by the way, the average waiting time to receive mental health care in Canada is 4 months, which is a month longer than 90 days. However, there was a surprise at the last minute. Just before the vote, a new feature was introduced. Heretofore, psychiatric illness was excluded from MAID. However, in the last minute surprise, this law that passed said we will sunset the exclusion of psychiatric patients in 2 years while we develop protocols. Well, there has been a tremendous amount of blowback about that, particularly among psychiatrists. For example, the organization that includes the chairman of psychiatry of all Canadian medical schools, all 17 medical schools, basically wrote a letter to Parliament calling on them as the deadline approached, which was March of this year, to hold off expanding it to people with mental illness, joining a number of people of various professions and lay public. So the Parliament heard that, and rather than pulling back from psychiatric euthanasia, they said, okay, we'll wait 1 more year. So now it's been extended to March 17th of 2027, when Canada will open to psychiatric patients, and based on the extraordinarily active euthanasia situation there, we will expect Canada to be the most active and vigorous euthanasia regime for psychiatric patients in the world, starting next March. Interestingly, just last month, a bill was introduced trying to say, let's not do mental disorders. Let's go back from that mental disorder is not a grievous and irremediable medical condition, which I'm actually going to try to address before we're done, and to try to basically close that door that had been opened for next March, and it was defeated, 167 to 150. So the door remains open for next March for psychiatric patients. And they've just made it clear that psychiatric diagnoses include substance abuse. So addictions will also be potentially eligible for euthanasia in March of 2024. This is a colleague in Canada who wrote to me about this and said, I'm in Canada and I have 2 patients who both have borderline personality disorder. They're eagerly waiting for mentally ill people to be included in MAID and writing letters to legislatures, et cetera. Every session we have is, why are you making me suffer? They also talk about how it's approved in Belgium. I feel I can get nowhere in treatment, as this is the topic every single time. So the anticipation of euthanasia for many psychiatric patients is already interfering with the very treatment that might prevent the need for that. And like Belgium and the Netherlands, there is an active organ donation that's been happening in Canada. And now there's talk about lifting the so-called dead donor rule. In other words, right now, the rule is you have to be dead before they can harvest your organs. What's now being discussed is organ donation by euthanasia, namely, you put the patient under anesthesia, and while still alive, you harvest their organs, because organs from a living person are really the most robust and the healthiest. And then after you've taken out the organs that you want to harvest, then you crank up the anesthesia and finish the euthanasia. Brief mention of the United States. The United States, we've had physician-assisted suicide since 1997. There are 11 jurisdictions that allow this. We do not allow euthanasia in the US, although attempts are being made to expand to euthanasia in many of these states. And it is for terminal illness only, people who are expected to die within 6 months. But one of the important things is we still have the ethical standard that patients are allowed to refuse treatment. So, for example, a patient can turn themselves into a terminally ill case, say if they have end-stage renal disease and they're offered dialysis and they refuse dialysis, they have effectively made themselves terminal, and then they would be eligible for physician-assisted suicide. Psych illness in the US is not explicitly excluded, and therefore is subject to the controversy as to whether there's such a thing as terminal psychiatric illness. But by the way, I want to mention that Oregon and Vermont in the last 2 years dropped their residency requirements. In other states, you have to be a citizen of that state. So now physician-assisted suicide is available to any citizen in the United States who cares to travel to one of these 2 states if it's not available in their own state. But with regard to psychiatric, although it's not, it's understood not to be included, it's not explicitly and statutorily excluded. So the question is, are there terminal psychiatric cases? Well, this author and her co-authors decided yes, there can be terminal anorexia, and they published 3 cases of what they called terminal anorexia, provided all 3 with a box of barbs for assisted suicide. 2 used it and died from assisted suicide. The 3rd died from her anorexia first before that could happen. And that has caused a tremendous controversy, but it is a shoe in the door, a camel's nose under the tent, whatever metaphor you want to use, a sharp end of a wedge that will see inevitably, as history has shown, in all jurisdictions that permit these, there is an inevitable expansion. And a colleague in Colorado has said that now in commitment hearings, involuntary commitment hearings, one of the criteria in the US for involuntary hospitalization is you have to show that there are no lesser restrictive alternatives. Well, since the publication of this paper, some defense attorneys citing this paper have argued that assisted suicide would be a lesser restrictive alternative to hospitalization, and arguing the court, rather than hospitalizing my client, the court should allow her to have assisted suicide in the cases of anorexia. All right, let's turn into the some of the ethical issues. As an ethicist, I want to touch on these. They're very important. The way I see it, unethical ethics are better than no ethics at all, that they say to each other. I'm not sure I agree with that. And a very important ethical issue at the basis of this psychiatric discussion is the concept of parody. We've long been talking about the importance that psychiatric patients should be considered in the same vein as somatic conditions, treated the same way, covered with insurance the same way, have access to similar array of resources. And of course, once you open the door to any condition being eligible for assisted suicide or euthanasia, then in the interest of parity, that's going to include psychiatric patients. Sort of an interesting, what I consider unintended consequence of the parity platform. So in the interest of justice and fairness, which is really what parity is all about, wherever you draw the line, people just on the other side of the line will say, why not me? 6 months prognosis, why not 7 months? Cancer, why not ALS? Why not multiple sclerosis? Why not schizophrenia? So there is you can call it a slippery slope. You can call it, an expansion in the interest of justice and fairness. It's very, very hard to prevent these expansions, and we have seen in every jurisdiction this pattern of expansion. Now, I want to say that the AMA, the largest medical organization in America and probably the largest national medical organization in the world, has repeatedly said that physician-assisted suicide and euthanasia is fundamentally incompatible with the physician's role as a healer would be difficult or impossible to control and would pose serious societal risks. They said that in 1994. It was reaffirmed in 2009. It was reaffirmed in 2018, and it was reaffirmed again last weekend. They had yet another run at it, and the AMA House of Delegates last weekend reaffirmed that it is not ethical to provide assisted suicide or euthanasia. The American Psychiatric Association follows the AMA, and I actually personally was involved in helping to craft this and pass this. And we wanted to make a special statement at the time, a signal to Belgium and Netherlands that was euthanizing psychiatric patients, and a signal to what might be and will now eventually happen in Canada. We wanted to specifically talk about our patient population. So we passed a resolution that said a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person, broad category, which includes psychiatric patients, for the purpose of causing death. So these are the current ethical standards that, by the way, have evolved over the course of centuries, all the way back from Hippocratic times, a venerable history in medical ethics that have been studied with scholarship, with a great deal of clinical experience. These are not just off the cuff, shoot from the hip. I mean, the Committee on Ethics and Judicial Affairs held several very, very deep consults in order to determine this. By the way, the AMA also currently says the preferred term is assisted suicide, not death with dignity, aid in dying, and so forth. All right, now there's several really important questions that I just want to raise. I just want to put them out there with regard to psychiatric patients. First, questions involving the patient. For example, how much is the desire to die a symptom of the psychiatric condition itself? How does a disorder which disrupts mental life undermine the autonomy required to make an irreversible decision, as autonomy itself is a function of mental life? What are the coercive influences of family dynamics, something that we encounter a great deal in psychiatry? Has the patient really accessed state-of-the-art treatment without constraint of finances, access, systemic inequities? Does it even matter? And some important questions with regard to the doctor who is determining the eligibility for euthanasia or providing it. How can the practice of preventing suicide be reconciled with providing it? What is the fundamental ethos of psychiatry with regard to suicide? How does having a domain of acceptable suicide affect public health efforts at suicide prevention? Is a psychiatrist's role in suicide prevention limited only to those who have a diagnosable mental disorder? Don't we have skills and duties that transcend the requirement for any diagnosis, where we can help any patient who is demoralized, who is in despair, who is unable to see a path for a special future? Or do they have to actually have a bona fide mental illness for us to be of value in this discussion? And you may know that there is no jurisdiction in the world that requires patients, except in Belgium, any patients, we're talking about somatic patients, to have a psychiatric evaluation as part of the determination of their eligibility, to at least give a psychiatrist or other mental health professional a chance to see if we can deploy some of these skills that may transcend any specific diagnosis. What is the role of countertransference and projective identification in the psychiatrist's assessment of futility? That's a technical term that will be familiar to the mental health professionals in the audience. I'm not going to take time to go into that, but it's a very important question. And how is futility determined in psychiatric disorders? Is it comparable to somatic disorders? So I want to focus myself right now for just the remainder of my time on this issue of futility. Different words have been used. It's irremediable, it's untreatable, no prospect of improvement. This is part of the statutory criteria in all countries that allow these procedures. So what about futility in psychiatry? And I maintain to you that futility in psychiatry is not well defined, is not generally agreed upon, may not even exist because of a variety of factors that interfere with the determination that something is futile. Let's look at these factors. First is unpredictable diagnoses. Here's a study that shows that psychiatric diagnoses, both inter-rater diagnoses and test-retest diagnoses, are not stable. They're unreliable. In fact, diagnoses in this particular case of major depression are so unreliable as to be almost useless in clinical practice. For major depressive disorder, it had a kappa of 0.28. Those of you who understand what that means will understand that's a low number. I won't explain it further. So remember that diagnostic reliability, which is only 66, 70%, 76% at the best, a diagnosis is critical for prognosis. You cannot tell what the future is going to be with or without treatment unless you're clear what's going on here. What's the diagnosis? What do we know scientifically and from clinical experience about this? So diagnostic fluidity means prognostic fluidity. So that already sets us up for problems with prognoses. Every study of prognosis in psychiatry has basically said it's not well developed. It's not really a significant exact science. Former president of the Canadian Psychiatric Association said an extensive review of the literature shows we can't predict irremediability when it comes to mental illness. There's a big difference between being able to predict the declining course of a well-known medical ailment with understood biology, even not with 100% certainty, versus making unpredictable assessments about the course of mental illness. And a special advisory group that got together in Canada basically concluded the same thing, a whole panel of experts. There's no evidence anywhere in the world's literature that supports being able to identify irremediability in individual cases of mental illness. Then there's the problem, especially in psychiatry, with treatment accessibility due to inadequate manpower, inadequate time of the clinicians that are there, coverage, the stigma, the issues of ableism and structural racism. The World Health Organization said the #1 cause of inadequate recovery from mental disorders are inadequate access due to finances, inadequate facilities, not enough treaters and experts. In fact, this particular study in Canada showed that if you look at just people with depression, only half of those with depression in this study's conclusion received either minimally adequate psychotherapy or minimally adequate antidepressant therapy, only 1 out of 2. There's another study showing that 300 eating disorders patients are on the waiting list for treatment in Ontario for a specialty center of eating disorders, and eating disorders do require very specialized treatment. The average waiting time for an eating disorders patient is 417 days. The maximum waiting time required for a non-terminally ill patient to receive euthanasia in Canada, 90 days. Finally, there's so many different treatments that we can offer in psychiatry, so many possibilities that can be applied. Some of those possibilities may be available in some places. Some possibilities may, the local caretakers may not, the clinicians may not have experience using it, such as clozapine, for example, or ketamine or psilocybin, which is now emerging. There's so many. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. So here's the problem, okay? The 2 suicides, those that's to be prevented by us and those that's to be provided for us, okay? When you have a doctor providing suicide, you're outsourcing your suicide. It's a moral outsourcing, which removes the responsibility for suicide, which has been a socially forbidden act, by giving it to a physician and calling it a medical procedure. Now, suicide should not be stigmatized. However, part of suicide prevention is having suicide as a taboo, as it has been since time immemorial. Please do not underestimate that feature of suicide as critical in any suicide prevention effort in any society. And I maintain by making this into a medical procedure, outsourcing the morality of it in that fashion to a physician and sanitizing it, removes this critical feature and confuses these two different kinds of suicide. In this particular cartoon, you can see the suicide prevention program and the assisted suicide program, and you can see which side has the ramp and which side has the steps. There's a whole emerging literature on suicide contagion that has long existed in societies about how suicide can spread when it begins to occur in a community, in a society, and whether or not these two different kinds of suicides are basically fueling suicide contagion is something that's being studied. So, for example, here in Oregon, in the United States, 1998, when assisted suicide was legalized, to 2018, in the course of that period of 20 years, the overall increase in suicides in the US was 28%. However, the overall increase in suicides in Oregon was almost 50%. That delta is 75%. So we've seen a skyrocketing of suicides in the first state in the nation, the longest state in the nation that has been providing assisted suicide. Suicide contagion? Don't know. Hasn't been studied yet. It was legalized actually before it was studied. So here may be the psychiatry of the future. You can have psychotherapy, you can have medication, you can have any one of a number of somatic therapies, electroconvulsive therapy, transcranial magnetic stimulation, vagal nerve stimulation, ketamine, psilocybin. You can have residential treatment, or we can help you to suicide. That is actually the paradigm now in 2 countries, soon to be a third, and potentially here. I maintain this inverts the fundamental ethos of psychiatry, who we are and what we do. We prevent suicide, not provide it. It is a core, fundamental mission that is the very definition of the profession, the bread and butter almost of our everyday. We have the therapeutic attempt to ameliorate symptoms. We help build coping mechanisms for demoralization and discouragement, mobilize support systems. We help people understand the context of suffering. Our job is to help people find a path to a better future. Indeed, if we can't resolve suffering, we can even help people make meaning of unresolved suffering. And by the way, we can do all of this even without a defined psychiatric diagnosis. So this may be the euthanasia of ethics, psychiatric ethics as we know it. Again, the editor of the Journal in Ethics and Mental Health, just as the Pope shouldn't perform abortions and the Dalai Lama should not take up arms, psychiatrists shouldn't counsel or abet suicide, for in doing so, we've misunderstood and betrayed our vocation and profession. Validation of assisted suicide or by psychiatrists or suicide is therapeutic and professional hypocrisy. My own mentor, the former chairman of psychiatrists, psychiatry at Johns Hopkins, it says that psychiatrists are involved with, if physicians, if they isolate patients, sustain their despair, revoke alternatives, stress examples of others choosing to die, and sweetening the deadly poison by speaking of death with dignity, even if psychiatrists succumb to this complicity of death, what can be expected of the lay public? As Churchill said, never give up, never give up, never, 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 never. Thank you very much. And I know we may not have that much time for questions, but I'll entertain those that may be available.
Thank you so much, Mark. Extraordinary, extraordinary, fantastic presentation, so comprehensive, a tour de force. I'm going to hand over to, I think the webinar will stay on beyond the hour, but just in case it doesn't, hand over to Catherine for any questions through the Q&A that you can present to Mark.
Okay, thank you so much, Mark. Some of the questions are about your appearance, and some of them are about where people live, which I will hang on to. Thank you for indicating where you live, those who heard that conversation at the beginning. Louise Andrew wants to know if the 1 or 2 hours in the Netherlands includes the euthanasia.
No, the 1 or 2 hours that I was referring to was the assessment. What often happens is at the end of the assessment, if euthanasia is approved, then a date is set at a later date. And what one often sees is patients going back to their families, saying their goodbyes, sometimes having goodbye parties. I mean, the whole thing can get into sort of a morbid romanticism. And as the date approaches, very often what happens is the euthanist comes to the patient's home and euthanizes them in their own bedroom, in their own family home, surrounded by their family. So it's all very cozy. Often patients will also go on to the funeral home in advance after having been approved and pick out, their coffin and pick out their music, and pick out whether or not, some of the funeral homes are offering, support dogs and animals that can sit with you during your euthanasia. I mean, it's a whole industry.
Frank, do you have questions?
Yes, the next question is from Joseph Marine. Do we know what drugs are used for lethal injection? Is there a standard protocol?
Yeah, so that's a very, very interesting question, because the drugs, tend to vary. And to tell you the truth, for me to try to recall what I've read about which drugs are used, I don't want to mislead you. I will tell you that with regard to assisted suicide, that there have been various cocktails tried that involve typically barbiturates, and there are a group of people that have been experimenting with different concoctions in certain cases of assisted suicide, and those experiments about what can best kill a patient most adequately, because especially with oral assisted suicide, sometimes it doesn't work, sometimes people vomit, sometimes it takes a day or 2 or 3. So those who are promulgating this are always in search of a more efficient way of giving oral death. And they're doing those experiments not within the context of any accepted ethical human experimental paradigm. No institutional review board, no submission to see, about informed consent and so forth. These are rogue experimenters, and most of them are in Washington State, some of them in Oregon. So that's probably the best I can answer for that question with any degree of reliable accuracy.
Thanks,
I could just add that the protocol that's recommended in Quebec is first sedative, like a benzodiazepine, next an anesthetizing agent, and third drug to paralyze the breathing muscles, like curare type of drug. And those are given in that order. And so the person is presumably put to sleep and then has their breathing stopped. Yeah.
Thanks, Catherine.
And from what I've read, that's somewhat similar to what I read about in Benelux.
Frank, is there another question from the audience?
Yes. Should organ donation not be allowed by psychiatric euthanasia patients to avoid this virtue trap? You spoke about the virtue trap earlier, Mark.
Well, look, I think if it's not clear already, I feel that all assisted suicide, physician-assisted suicide, and euthanasia is like with the AMA, not consistent with the ethics, proper ethics of being a physician, and also bad public policy, even though I'm focusing on psychiatric. So, should it not be allowed? I don't think any of it should be allowed. But here's the problem. I mean, I'm not, basically in charge of these societies. And once the cat is out of the bag, as I already explained to you, this slippery slope, this sort of natural, and if you will, moral expansion that goes on, that keeps changing, the fulcrum that balances, murder on one side for, acceptable euthanasia on the other side, that fulcrum, keeps changing. And it's very, very difficult in the interest of parity. I mean, look, the Canadian Psychiatric Association, when before that sunset clause was passed, the Canadian Psychiatric Association, unlike the American Psychiatric Association, came out with a statement that said, in the interest of parity, psychiatric patients should not be excluded from any of the end-of-life medical procedures that are available for anyone, thus endorsing psychiatric patients having this. They didn't explicitly come out and say it, but it was damn near close. Psychiatric patients should not be excluded in the interest of parity. So our interest is parity. We're sticking to that. And if the consequences are that psychiatric patients should share, to have euthanasia, to have organ donation in the face of that, that they shouldn't be excluded. And frankly, it's very difficult to make the moral argument of any line drawing, frankly, but especially with psychiatric patients. It's very difficult to say, not you, from a legal and philosophical standpoint. That's why I think that the only tenable approach under these circumstances to doing this is not to make the argument from that point of view, but to make the argument from the point of view of futility and all the different arguments about that I gave you about why futility is anathema in the context of psychiatric disorders, and therefore they do not fit the paradigm that's being deployed for everybody else.
Thanks, Mark. And Catherine, we just have about 5 more minutes at the most for any questions.
They're mostly comments. Dr. Louise Andrew, who's an American living in the US, many interesting comments about our society, and I agree with you. It says at the end, it's well-intentioned, but uninformed students and residents who are pushing this issue with the AMA, which I guess is the American Medical Association, and that Dr. Andrew has contacts with them. Mark, you might have contacts with them too, but if you...
Yeah, let me just say, and by the way, I know Dr. Andrew. She's actually an American living in Canada, and practicing in Canada. This latest round last weekend at the American Medical Association, where once again, it was they were asking 2 things: to either basically lift the prohibition against physician-assisted suicide, ethical proscription, or to simply go neutral, which much has been written about how going neutral is basically the same as endorsing. And the primary people who were pushing for that were the students, the younger generation. I mean, I think that's very interesting. And as I said, there's now in Europe a whole generation of physicians who have never known the practice of medicine without this option.
Thanks, Mark. And Frank, just checking if from any of other questions that you can...
Yes, thank you, Sinead. So from Ronald Piles, has there been any publications on what seems an obvious conflict of interest when a psychiatrist is in the position of euthanizing his or her own patient?
Yes, and those concerns have been set in the context of this technical issue that I passed over quickly with a nod to the mental health professionals about transference, countertransference, and projective identification. The idea is, first of all, it is difficult to treat any patient, but some psychiatric patients are especially difficult, particularly trying. Many of them you have to grapple with, multiple attempts at suicide and hospitalization. So your own exhaustion plays in, and also the way in which the patient's hopelessness can be psychologically injected into the treater, not just psychiatrists, but all physicians. This goes by the technical term projective identification. Patient works on you to help to unconsciously to get you feeling the same way they feel, and then they see how you handle it. And it's an interpersonal dynamic. So being injected by patients' hopelessness, being exhausted, all of these things put all physicians, not just psychiatrists, in a very conflicted position about whether or not they can be objective for the decision to get rid of this patient. One of the things that I have, when I go around lecturing, giving grand rounds at various places, sometimes I'll have a meeting with the residents. And I tell the residents, I said, look, I've been a psychiatrist for 40 years. You guys are just in your first through fourth year. I said, if you have never sat with a patient, at least once, who has been threatening suicide and so forth, and thought to yourself, and never say to the patient, in your own countertransference, thought to yourself, why don't you just go ahead and do it already? And, leave me alone. Then you haven't been practicing long enough. Because eventually, if you practice psychiatry, you will have that feeling. You will work through that feeling. You will talk with your supervisors about that feeling. You will not act on that feeling. You will recognize that feeling as countertransference and everything that you learned about how to deal with those. But that's what you'll feel. Now, imagine a physician or clinician who has not been trained to grapple with that kind of thing, who has not been trained to separate that feeling, to recognize when a feeling may not actually be my own feelings, the patient's feeling, and that my decision may be, influenced in an inauthentic way. I can tell you that this concept is not generally understood by most clinicians, and it is understood by psychiatrists. So these are the ways in which this conflict of interest issue tends to come up in the literature.
Thanks, Mark. It's just incredible articulation of these concepts. Just fantastic. Thank you. I'll just check with Catherine, any final question?
Salvador, whose last name I don't want to try pronouncing, would like to put back the futility slide for a moment. Salvador would like to see the futility slide, if you can do that, Mark.
All right, let's see. And I see people are still hanging around, so yeah. Am I. Okay. Oh.
That must be it, yeah.
So, and by the way, these are just several arguments. There are actually many more here. I just published a paper with some colleagues addressing futility and anorexia. The fact is in these ways, psychiatry is weaker, is more vulnerable, is less of an exact medical science than other fields of medicine, which I do not want you to take as my implying that assisted suicide and euthanasia is fine in those other fields. But as we focus in psychiatry, these are real problems in our field. And the whole idea that, the entire nation of Canada is poised and ready to roll in, a matter of 5 months. 5 months from now, they're going to open their doors to psychiatric euthanasia and really be the most active psychiatric euthanasia regime in the world. Whether they will, I don't know, Catherine, you may know this. I assume you have to be a Canadian citizen at this point.
Yes.
And that will probably continue, but one never knows, right? What starts off looking one way eventually expands through, demand, as well as, the sometimes, understandable arguments that ask for that kind of expansion. But you can see this is the way in which we in psychiatry, we're not ready, and we will never be ready, at least not in my lifetime, which I hope will still be a considerable number of years.
Thanks, Mark. Frank, is there a further comment or question from the audience?
Seeing if there's anything further. Joseph Marine made a comment. Many students and residents testified against the resolutions at AMA 2 as an addition. Could you please reproject the access ramp to assisted suicide slide? This is a very compelling health equity issue, discrimination against those with disabilities. Thanks.
Yeah. Yes. Well, one of the problems is we're seeing in Canada that people with disabilities often need resources, and those resources are often not available to them. A government doesn't provide, insurance doesn't cover. There may be, inherent ableism with prejudice against disabled people, including, the idea, which has ominous overtones to history, of lives that might not be worth living. We saw, for example, in the COVID epidemic, the alacrity with which life support was withdrawn from people who were disabled much more easily than it was for people that were not disabled, especially when we were dealing with shortages of ventilators and so forth in the terrible early days of COVID. So this creates, a tremendous vulnerability of, the disabled class of people who, are getting the implicit, if not explicit, message that their life may not be worth living. And there have been a number of cases now, very well documented in Canada, because they have so much experience up there with it, of people who were not given what they needed, ramps, housing, nursing care, and so forth, who were offered as an alternative. Well, we can't give you that, but we can give you euthanasia. Would you like euthanasia? And some of them have said, yes, thank you.
Mark, if you would just show that slide. I think that's what also you had a slide that just shows the choice that the person in the wheelchair had.
Okay.
It's a well-known slide.
That was done by Amy Hasbrook, who's involved with what's it? I lost the name of her organization, but it's in the US and Canada. Not
look
yet.
At this quote. Look at the quote from the ethicist: the distinction between whether death is hastened by a medical professional or by the suffering person is becoming essentially meaningless and irrelevant.
Thank you.
Yeah, Amy, you know what? Thank you for saying that. I thought I had that on this slide. In another version of this talk, I have Amy's name. So thank you. I will include this for next time.
Thank you. Just checking, Frank or Catherine, any further comment, and we'll wrap up.
One of the anonymous attendees spoke here. The disability paradox being that physicians undervalue the lives of persons with disabilities. Congratulating you, Mark, on this is the most cogent presentation that I've ever seen. Please do provide. So yes, this talk being recorded. Yeah.
Thank you.
Although we actually didn't record the Q&A, right? Am I correct about that?
That's my understanding. Yeah, the recording at the Q&A from a privacy point of view has not been recorded. Yep.
Right.
Dr. K wants to know where it will be available, the recording.
So Dr. John Kleinsman will send out a newsletter. Well, he'll give it to me and I'll send it out and include the recording of Dr. Komrad's plus the previous webinar a few months ago, and that will come out in a Christmas newsletter in the next few weeks. You
could perhaps suggest to John that he include a link to Amy's cartoon, although it's quite easy to find on the internet. But yeah.
Let me do this before we leave, and that is this is my email address. If anybody wants to email me, is it showing up?
Yes, it is.
Okay. So mkomrad@me.com, and I maintain a list of correspondence, about 600 people with whom I occasionally share articles that are relevant to this, news developments that are happening in different countries relevant to this. Certain kinds of links and interviews, maybe just a few times a month. So if you want to be in my mailing list, you can email me here and I'll be glad to add you. And once this recording is available, I will be sending the link to my entire mailing list, so you can get it that way.
Thanks very
And
much.
also, I assume we're going to have it on our website of doctorsayno.net.
That will eventually happen. Yes, Mark.
We're working on improving the website.
Yeah. So just to finish, to thank Mark, extraordinary presentation. I was just thinking, as you said, Mark, it's a very hard topic. It feel like that we're injected by people's hopelessness on the topic, but the gift has been your extraordinary skills, superb teacher, critical thinker, and an extraordinary communicator. So you've lifted our spirits despite the topic being so hard. So thank you, Mark, for the gift of who you are and all the commitment you've given to this, to researching and presenting and communicating. So to thank Catherine and Frank for overseeing the questions and answers. We will send out the notices for the 2024 webinar series when they're available. We would aim for probably 3 again in 2024. You are welcome to email Mark or me with suggested speakers, and we're keen to facilitate speakers in a variety of languages. That would probably be our challenge for 2024. So with that, we'll come to an end. And again, once again, thank you, Mark, for the gift of all your skills.
Thank you so much. And I hope, but maybe I've changed a few minds. And if not, at the very least, I've helped people understand this is a far more complicated issue than perhaps you realized.
Thanks, Mark.
Thank
Thank you,
you.
Mark.